Hello, my name is Alejandro Garcia, and I would like to begin by thanking the ABSA committee for allowing me to present my research today. I will be presenting a research titled Improving Neurologic Outcomes After Respiratory Arrest Using a Porcine ECPR Model. I have no disclosures. The use of ECMO in children has increased fourfold in the last decade. ECPR has been shown to dramatically improve survival after in-hospital cardiac arrest from 27 to 40% in children. Neurologic complications, unfortunately, are very high after ECPR, with many children sustaining brain death, and for those who sustain CNS infarctions or hemorrhages, this greatly impacts their survival. In infants with congenital heart disease who were placed on ECMO post-cardiotomy, hyperoxia in the first 48 hours is an independent risk factor for mortality. In a meta-analysis, children with hyperoxia during ECMO support was found to be common and independently associated with increased mortality. In adults requiring ECPR, even moderate amounts of hyperoxia with PaO2s in the 100 to 300 range was associated with increased mortality compared to normoxia. So no guidelines exist on the correction of hypoxia in patients following ECPR. We hypothesized that hyperoxia following a respiratory arrest will lead to a reproducible neurologic pattern of injury, and that brain biomarkers could be used to detect this injury. We used 4-week-old domestic swine to target an adolescent porcine model. These pigs weighed about 9 to 10 kilograms. We mechanically ventilated them. We used the femoral artery and vein for hemodynamic monitoring during ECMO. We placed a Lycox monitor in the posterior brain parenchyma so we can measure brain parenchymal oxygen saturation directly. We performed the respiratory arrest with occlusion of the endotracheal tube for 7 minutes. And this was based on work from one of our collaborators that established this model, and this performed a very reliable cardiac arrest. And an ultrasound was used to confirm asystole. We performed CPR for 20 minutes. We cannulated the pigs via the right neck, similar to a neonate. We used 8 French arterial cannula in the common carotid and an 8 French venous cannula in the right internal jugular vein. We initiated ECMO flows at 100 cc's per kilo per minute, and we ran ECMO for 4 hours. We obtained biomarkers sequentially throughout the experiment, and we obtained postmortem histology. We had 4 arms to our experiment. We had 2 arrest arms. So these were pigs that obtained ECPR and were on ECMO. The first arm is the hyperoxia arm, where these pigs were maintained on an FiO2 of 100% given via the ECMO circuit. And the normoxia group, which had an FiO2 started at 21% and was slowly titrated up to target a saturation of 92 to 98%. Our control arms included ECMO, but without the arrest, and also included a hyperoxia and a normoxia arm. And this is our experimental model. We initially looked at the brain saturations using our Lycox monitor. We found that in blue and gray, which are our hyperoxia arms, the blue being the arrest and the other being the non-arrest model, both of those experimental arms have significantly higher levels of oxygen being delivered to the brain as composed to the normoxia groups. We looked at lactate as a marker for end organ perfusion, and across all 4 experimental arms, we did not see a difference in lactate that was statistically significant. We then performed histology on the postmortem. This was blinded by the pathologist who was evaluating the brains to the experimental arms, and they evaluated the putamen and the caudate to assess for neurologic injury. And the neurons were classified as either viable, ischemic, or ischemic necrotic. When we counted the number of viable cells, and we looked at the arrest hyperoxia and arrest normoxia, we saw that there was significantly less viable cells in our arrest models compared to our control. When we looked at injured neurons, our arrest model with hyperoxia had significantly higher injured cells compared to the normoxia arrest in our control. And when we looked at the most ischemic necrotic cells, the arrest hyperoxia had almost exclusively ischemic necrotic cells compared to the other arms. And this is a 40x magnification of an example of a control hyperoxia piglet, where there are a few neurons that have some ischemic changes, but generally they're all healthy and pink. And you can look at the ECPR hyperoxia pig on the right, where most of the neurons are necrotic. So in conclusion, we established a reproducible pediatric porcine model of ECPR following hypoxic arrest. This model demonstrated differential injury to the forebrain following different strategies for hyperoxia correction. This model will be used to further study strategies to minimize reperfusion injury and mitigate neurologic injury. As far as future directions, we're still working on analyzing the biomarkers, which unfortunately wasn't ready by the time of this presentation. We also want to look at whether correction of CO2 levels following arrest also influences the degree of neurologic injury. For our pigs, we've maintained this pretty consistent, but this has also been shown in the literature to affect outcomes. We would also like to use functional MRI to assess the cerebellum basal ganglia during the ECMO run to see how these pigs are functioning. And ultimately, we like to perform survival models, be able to resuscitate these pigs with ECMO, bring these pigs back, decannulate them, and then be able to do some functional studies to see if the neurologic injury that we're seeing in the acute setting is translating to any functional outcomes. I'd like to thank my collaborators at Johns Hopkins, as well as the APSA Foundation for this Grosfeld Award, which allowed a lot of this pilot work to continue. Thank you.